All right, good afternoon, everybody. Welcome to January 2024 office hours. Thank you for coming today. Get started on our agenda, and I hope everybody had a good new year and the year's starting off right for you all. So let's get moving here. We're going to go through some policy and procedure updates. We're going to have NetSmart updates today. Going to do a little bit of information on the CES tool. Initial appropriateness reporting requirements, our MAP plan of care upload status as a lead health home, some information on redesignation scoring process, and the 1115 waiver. Just talk about that as well. Before I move on, I just want to make sure folks can hear me okay, and the chat function is up for folks if they want to utilize. If I could just get confirmation.
Yes, we can hear you.
All right, great, thank you. All right, so here we go. Any questions along the way, feel free to ask or wait to the end, however you want to, use the chat. But we're going to touch on a number of policy and procedure updates that happened over the last couple of months. We had the eligibility and appropriateness criteria for health home updated, our QA performance improvement and compliance policy, which is a new rendition of our quality and performance improvement policy, health home outreach and engagement, staffing qualifications, transfer policy, our initiating and maintaining OPWDD FIDD level of care determination policy, and last but not least, the non-health home policy. And then there are a couple of policies coming down the pike. So before we get into those policy review, I just wanted to remind folks that we have all our current policies and procedures available on our website. So feel free to hop on there, and the event you want to look something up or just want something clarified, and you can always reach out to the health home as well. So with that, I turn it over to Jessica.
Hello, you can hear me okay?
Yes.
Okay, perfect. I just never know with WebEx. So we did review this policy when we had our special office hours in December, but now that it has been published and out, we just wanted to go over it again for everybody. This is our updated health home eligibility and appropriateness criteria policy. First and foremost, this is replacing our qualifying conditions policy. So we've renamed the policy because now there's going to be this emphasis on the appropriateness criteria. So qualifying conditions to now health home eligibility and appropriateness criteria policy. With that, we do have a newer version of our eligibility screening assessment. This tool was for adults and children. It used to be under the assessments tab in NetSmart. It is now moved to the bottom left-hand side of the screen under additional forms. You can view previously submitted assessments, but now to do a new one, you have to do the new version under additional forms. This needs to be completed for all newly enrolled members within 30 days of enrollment. If it is not completed within 30 days of enrollment, billing will reject for the following month. We have to send the appropriateness criteria and eligibility to MAP. So this is being pulled on a report from this assessment. So it's super important that it is completed within 30 days. If it's not, billing will Someone have a question?
I think you're good, Jess. It might have been just some.
Yeah, I was just gonna, okay, they're muted. So yeah, so make sure it's done within 30 days. If it's not and billing rejects, Courtney will reach out to you. And Taylor did also build a new eligibility screening assessment tool in DataDen. So you can go in there and check and see who doesn't have one done. You can go to the next slide. So moving forward, something that is new for our children's population only. In the children's population, you have to complete this eligibility and appropriateness criteria assessment within 30 days, and then everyone will need one completed on an annual basis. So yearly children's health home care managers will have to go in and complete an updated eligibility and appropriateness assessment. The other thing to keep in mind is anytime there is a status change for the member, whether they're an adult or a child, the screening has to be updated within 30 days. So if you have a member that's in diligent search, they're enrolled, you move them into diligent search, you end up re-engaging them and you want to put them back in enrolled, you'll have to remember that you have to go in and update that assessment because that needs to re-trigger to send to MAP the eligibility and appropriateness for that client. So if you have a member that changes status for any reason, so whether they go from diligent search to enrolled, or they go pended for incarceration back to enrolled, anytime there's a change in that member's status, you have to update the eligibility assessment. Does anyone have any questions on that? Okay, you can go to the next slide. Again, this is just reinforcing the direction that we've been given by the state that we need to now report initial appropriateness to the state. That's why we have this new assessment. It's why it has to be done within 30 days because it's being pulled on a file. So Courtney's going to pull a file and that will send this information to MAP. And as you can see, billing technically is cut off as of 2/1. So anybody who is newly enrolled in Health Home, they have to have one of these completed. If not, on and therefore after 2/1, billing will reject if you do not have a eligibility assessment completed. And then once again, if anytime you change a member's status, it's super important that you remember to go in and update that screening. Go to the next slide. So we just wanted to touch base again on the CES tool, that continue eligibility screening tool that is for adults only. So annually, children are going to have to do an updated eligibility assessment, and then annually is when the CES tool starts on the adult side. So for adult members enrolled in Health Home for 12 months or more, they have to have this tool completed. The due date for your initial CES tool is the due date of your comprehensive assessment. So you can, there will be reports built in DataDen that can help us track all of this, but you will be using your annual comprehensive assessment date as the due date for your initial CES tool. If the member is Health Home Plus, you will not complete the entire tool. You will only complete the demographic portion of the tool, and you will answer that they are Health Home Plus, and then that will instruct you to stop answering any further questions. And then you will not have to do that until step down occurs. So you have a member that is now Health Home Plus step down. They're in Health Home Plus step down for billing for 6 months, but they're in Health Home Plus for the step down for the program for 12 months. So those members who move from Health Home Plus down to Health Home Plus step down, their initial CES tool will not be for 12 months from the date of Health Home Plus step down. Again, it's a lot of due dates to track, and we are working on building various reports in DataDen to help track all of this. Next slide, Travis. So with this CES tool, you can get a couple of outcomes. First, your outcome will be continued enrollment. This means that you've answered the questions. The outcome of the tool has told you that they will have another 6 months to be enrolled in the program. So once you do the initial tool, if the outcome is continued enrollment, then every 6 months thereafter, you will have to update the tool. If you complete the tool and it states disenrollment, you have 60 days from the date that the tool was completed to graduate that member out of the program. So you want to make sure that you're following the disenrollment policy and issuing all the correct forms if you're moving towards disenrollment. And we have seen one so far, I believe, more information needed outcome. This means that as you completed the tool, there wasn't sufficient information in the assessment to determine whether they should stay enrolled or be disenrolled. So at that point, what we're gonna do is work together with your supervisor, the health home care manager and the supervisor are gonna work together. You can loop in the health home if need be. You're gonna look at updated psyches, potentially HCSCNE information, talk to the care team to make sure you can get some concrete answers to the question on that assessment. And you have within 60 days, you have to complete a second CESS tool. And a second outcome of more information is not needed. So you have to gather enough concrete information to complete the tool and get an outcome of either continued enrollment or disenrollment. And then if it is disenrollment, you then have 60 days to complete that graduation out of the program. And with the CESS tool, there is the function that the supervisor does have to be involved in the tool. So that means that either it's being saved in draft by the care manager currently, and then the supervisor is going in and reviewing it and then finalizing it and saving it, or it's completed by the care manager, the supervisor's reviewing it, they're writing a note in NetSmart stating they have reviewed it. So there is right now, that's how we're tracking if supervisors have, per policy, supervisors do have to have oversight of the tool. Future state, we are working with NetSmart to get some sort of supervisor signature function or approval function in on the tool. Does anybody have any questions? Okay, we'll go to the next slide. This is just a little screenshot and a reminder. Again, this new tool was implemented on the 1st for the assessment tool and appropriateness criteria. And we're going to be updating some of the language in the CESS tool that we're not, when NetSmart makes those adjustments, we're not positive. We are waiting to see those in UAT. Again, and that supervisory signature will be coming at some point. Next slide. Again, for the CESS tool, this is just a screenshot from some slides that we received from the state, just restating some of those timelines that we have to stick with. So again, this happened on November 1st, that we now have to complete this tool every 12 months for anyone who's enrolled in Health Home, as long as they're not Health Home Plus or Health Home Plus step down. You're going to use that annual comprehensive assessment date to determine your initial date. If you get continued enrollment, you're going to complete this tool every 6 months. Next slide. All right, so does anybody have any questions on the policy that we just reviewed? Okay, next, Taylor and I are going to move into our quality assurance, performance improvement, and compliance policy. So Taylor, do you want to kick this off?
Sure. It's a mouthful. So this has changed from our quality assurance and improvement, quality assurance and performance improvement to quality assurance, performance improvement, and compliance. So there's a number of new components that are coming to fruition with the updates to this policy. The first of which is health home serving children HCBS members are added to our process audit schedule. So twice a year, each CMA that has a HCBS youth, they will have those members audited. And I believe Jessica is in the process of doing that to go out in the February quality notebooks. Do you have anything to add to that, Jess?
Nope, you covered it. Like Taylor said, part of our CAP back to the state for our HCBS audit that we had last summer. This was one of the items that was in there. And like Taylor said, I am in the process of completing those now, and they will be in your February notebook.
Awesome. Next slide, please. All right, so as you guys probably noticed, back in December, we had added the safety crisis and emergency plan to the monthly audits that are in the quality notebook as well. So those need to be completed within 60 days of enrollment for your kiddos. They will stay on those notebooks until they are complete. So If they go on those notebooks, that will serve as your level 1, and then the next month that they're not complete, they will go into a corrective action plan. There is that tab in Data Den to check any of your safety crisis emergency plans that have not been done. So I highly recommend utilizing that to capture any that need to be completed. The next is the appropriate criteria. So that has been added to our process audits and will be completed twice a year. And then the CES tool, we did not complete the monthly review on that for Quality Notebook in January, just because our report is not finalized yet. But as soon as that report is finalized, the CES tool will also be added monthly to the Quality Notebook. That way we can make sure that everybody is following policy on that. Next slide. Comprehensive chart reviews. So we're just finishing wrapping up all of our 2023 chart audit reviews. For 2024, we have some changes that are coming through based on redesignation, which Travis is going to get into a little bit later. But for redesignation, the weight of the chart review scores has been increased. So we're seeing a lot of that weight being put on these individual chart audits, and therefore we're just focusing a little bit more on these chart audits for the CMAs, and we'll be increasing the annual audit percentage from 5% of each CMA's total population to 10%. So we hope that it'll give a little bit broader of a picture of any trends that CMAs may be struggling with moving forward. Records that are reviews for HCBS enrolled youth will get 1 audit score per chart, and that will be inclusive of your chart audit and your HCBS audit score combined for the total score. And then moving forward again in 2024, any CMA who receives under an 85% on their comprehensive chart audit will be subject to a performance improvement plan. Next slide. This is where that compliance piece comes in. So as we noted, we renamed this policy to include compliance. AHI has developed a Health Home Compliance Committee. The Compliance Committee will meet quarterly and will discuss any compliance concerns, complaints, grievances, and review incident reports from across the last quarter. In addition, we do keep a monthly tally of office hours attendance, and it is required that a CMA has representation on office hours. We do realize that we record them and they are available on our website, but we do like as often as possible for at least a supervisor to be present. That way you can ask questions while you have us here. Especially if we notice that a CMA is struggling either on their comprehensive chart audits or on their quality notebooks. It is something that we are going to be looking at to determine if we need to set up a corrective action plan in order for folks to attend office hours. Next slide. Oh, and that's all I have on that. Does anybody have any questions on the new quality assurance, performance improvement, and compliance policy? All right, thank you guys.
All right, I'll take over on a less wordy title for a policy. Outreach and engagement. This was just an annual update to our outreach and engagement policy. Just one thing to mention here with all of our updated policies, as part of that compliance component in there. Moving forward, you're going to see in all of our policies, I know we've covered this, but you're going to see the health home, either the health home policy that we derived our policy from, the health home standard that this policy is meeting, or some sort of guidance document that has been issued by DOH. And those are all going to be on the header portion of our policies. We've included that to show you where our policy has been developed from. Also to loop in compliance, our chief compliance officer approves all of our policies. And if you have any questions on all of our policies, just a notice of receipt, and that if you have any questions to please direct them to the appropriate person listed in the policy. But for this one, there was no changes. Just an annual update, read through, made those minor tweaks to make sure everything was up to date. Does anyone have any questions for outreach and engagement or on policy? All right, next slide. Staffing qualifications policy. So again, just like those minor updates that I just talked about, we also received some clarification on the current process for background checks. I'm sure everyone was following this before because it's just what you would do naturally, but the wording in the policy just updated to make sure that all the background checks for serving someone under the age of 21, that care manager, they all need to be completed prior to that care manager serving that member. If they're under 21, you do have to have your background checks completed. We also got an updated memo and clarification written in a memo from DOH that we have to have the updated mandated reporter training completed, and it is an annual training for any care manager serving someone under the age of 21. So if you're serving someone under the age of 21, you have to have your trainings completed, and then you also have to have an annual mandated reporter training. The one thing I will state here is that your agency's policy may supersede this, and they may require it of all of their staff regardless of the age of the population you serve. So you should follow your agency's internal policy when it comes to that. Also with our children's population, we do have quite a bit of trainings that the children's population has to complete within the first 6 months. They, as in the state, has been allowing care managers that move between CMAs. So if you leave one CMA and you go to another CMA, they have been able to carry over those trainings to the new CMA. What the state has stated that is only allowable if it were completed within the last 12 months. So if I was hired by CMA A, I complete my required 6-month trainings, and then 4 months later, I decide to leave CMA A and I move to CMA B, those trainings would carry over with me. However, if I spent several years at CMA A and then I moved to CMA B, I would have to recomplete those 6-month trainings. Does anybody have any questions on that? Okay, next slide. Transfers, there was no update to this policy. Again, just noting certain things that it was approved by our compliance officer. This is an internal health home policy. This isn't based off of state policy. Currently, although some changes may be coming from DOH on how we perform transfers, but for now, this is our policy on how to complete a transfer. And we have recently combined our referral and transfer form all into one form. So it's super important that if you are completing this form, especially for a transfer, that you, on the top right-hand corner, you mark that it's a transfer, the date of transfer, and then make sure that you're filling out this form completely. We want to make sure that the accepting CMA has all of the information that they need, potentially even a warm handoff set up, that they are ready to go with this member. We've noted any type of environmental concerns, safety concerns that member may present to the new CMA. So you just want to make sure that they're getting the most up-to-date and best information when taking over somebody's case. And anytime we receive a referral or a transfer and the information is incomplete, whether it be from a CMA or if we receive an outside referral, we can always go back to that referral source and let them know that we can't accept that referral and or transfer until we get updated, more accurate information. So if you see or hear Courtney reaching back out to you, we're just trying to get the best information possible to transfer that case. Does anybody have any questions on transfers?
I do. This is Jackie Jackson. So I guess I'm having a problem with, it's got to be, all the information has to be there because so often the referrals I get do not have all the information that's needed. And sometimes if I'm unable to take a case, I'll just say to Courtney, we can't take this for X, Y, and Z. I don't feel I should be required to do the transfer and provide more information when I'm not taking the case in the first place, the client in the first place. Is that,
So-
am I making myself clear?
Yep, no, I hear you, but that wouldn't be a transfer. So sometimes we get referrals that do have limited information on it, and it's just by virtue of that referral source. It may be an emergency situation where that person making the referral has identified a need through maybe, you know, social services need, maybe it's a food pantry, maybe it's some sort of emergent need where they don't have a long history of working with that client. So they just get what they have to make that referral. Sometimes we get referrals from MCOs that are really kind of short and sweet. We've talked to the MCOs about doing a full complete referral. Some of them don't have the capacity to do that. So we're going to get referrals that have limited information on it. And we realize that we try to get the best referral policy possible. If we do get a referral that you as the CMA receive from Courtney, you have every right to turn that referral down or say to Courtney, I need more information if possible. If you receive a referral that you do not have the capacity to take or you don't want to take for whatever reason, you're not then transferring that case to anybody. What you're
Okay.
doing is you're just letting Courtney know that you're not going to accept it, and then she will re-refer to somewhere else. The transfer form is only to be used with members that that are actively with your CMA, that are actively enrolled, and for whatever reason are leaving your CMA, whether it be by choice to another CMA, maybe they're moving, to a county that you don't cover. That's when you would do the transfer form.
Right. I mean, I think for as far as the information goes, like that there's a mental health diagnosis on there. And I mean, then we're just doing a lot more digging, I guess, is, what I'm trying to say.
For the referral or for the transfer?
For the referral. So if there's no, diagnosis, nothing checked.
Sometimes we're going to receive referrals that lack some pretty basic information. Again, if you receive a referral that you feel doesn't have enough information on it, you can go back to Courtney and you can say, I will accept this if you can give me some additional information, or I can't accept it until I get additional information. And then Courtney will go back to that referral source and say, hey, we can't accept this until, and then we'll go back to you.
Thank you so much. I appreciate that.
Any other questions?
Jess, I just wanted to add that this is something that's occurred across the network. So it hasn't been any certain organization that we're calling out. It's been a number of us, our internal CMA included. So, it's a process that we're acknowledging that we need to tighten up. And I think for everybody's best interest, we should tighten it up, especially for a transfer scenario. It is something that the Department of Health is auditing. Omega is auditing, as you know, our health home right now. They're looking at referral source and eligibility and appropriateness when the person came into health home, when they got assigned to an organization and into the health home in general. So it's something that's prevalent and needs to be looked at closer. So we're trying to make steps and efforts to do that. And collectively, if we could look at that as a network, especially for those folks that are within our organization enrolled and we're seeking to transfer to another agency, we generally do have more information that we can provide on that referral form to help support a warm handoff and engagement. So
right. And just to know, Courtney's wonderful to work with. She always gets right back to me, that's not what I'm saying, just to be clear.
No, I'm saying collectively as a network, we've had this come up from most organizations at one time or another when they've put a transfer in, and we've been victim of it in our own internal, CMA. And as a lead, as a referral, we get inundated with referrals on a large volume. Sometimes we process through because we're trying to get things out expeditiously.
Right. Yep.
And we can improve on that all the way around. So this is not pointed to any one direction. This is a collective statement and effort for us as a network to look at helping each other out in this, so that we can make sure that when we do have someone enroll with us or transfer to one of our partner organizations in the network, that people have as much information as they could get to help with that process. So it's duly noted. We're just trying to take steps to improve.
Thank you.
Absolutely.
All right, we go to the next slide. Nope, one too many.
There one too many?
Yeah, I skipped one.
No, it froze. How about that one?
There you go, perfect.
There,
So
got
here's
it.
another very
Sorry about
wordy
that.
title. So this is our annual update to our initiating and maintaining our level of care eligibility determination for our OPWDD members. Most of them are our children. Again, there's been no update to this, no changes, just again, where we're pulling policy from, and that it's been improved by our compliance officer. This is not getting that level of care eligibility determination. This is just maintaining it. And basically that sits with the care manager to maintain that eligibility. Does anybody have any questions? All right, next slide. This is our non-health home policy. Again, no updates to this. Just we reviewed it, just annual update. No changes to the actual policy. Again, this doesn't even apply to everybody, but those who use NetSmart with the non-health home program. Does anybody have any questions on this? And if you do, this is where I would ask Courtney to chime in because this is her area of expertise. Nothing? All right.
Wait, hold on. This is Jared
Okay.
from the
Hi,
hospital.
Jared. Yep.
Hey, so this is in reference to people who don't have Medicaid. And if we have somebody who is incarcerated and then they get out of incarceration, and we technically can't find them, so we put them in diligent search when they get out of incarceration, because in this gentleman's case, I called the jail and they said he got out on the 28th. So technically I have to disenroll him now, is what the policy is.
It would depend on the date that he entered that setting.
Well, I
So-
put him in excluded setting, and I did not do the HMLs for the months that he was in the excluded
Correct.
setting.
Yep.
Then
That's-
he got out on the 28th of last month, and I've since put him into diligent search. So I ended the excluded setting for December, but
Okay.
hasn't popped up yet in this month. And Jackie, who's very diligent about going into MAP, he still hasn't applied for his Medicaid. So do I have to disenroll him from NetSmart? Only for him if he were to pop back up February 1st to have to go through the entire re-enrollment process again.
Right. It would depend on the date he entered. So this is a little bit tricky because this is where consent in the limitations on consent is going to trump the segments that we put into MAP. So if he was incarcerated for over 6 months,
He was not.
he was not. Was it 3 months or more?
It was in the area of 3 months.
Okay, so what we'll do is we'll give a little bit of grace here. With him, I would leave him in diligent search. So he entered diligent search on 1/1 essentially. So you have January, February, and March to re-engage him. Obviously, none of it being billable because he doesn't have active Medicaid. But you have 3 months to find him, and at the end of March, the system
so
will
when
disenroll
I'm
him.
sorry to interrupt you, but so when I do the HML, I just do a non-billable.
Yeah, because he doesn't have Medicaid to bill.
Okay, all right,
Typically, diligent search is billable, but because of his particular situation, he does not have Medicaid, so you can't bill. But I would continue to check that every month because he could
Oh,
potentially,
yeah, we plan on doing so because
yeah.
his situation, he was Health Home Plus prior to going in because he was homeless, and now he's homeless coming out
So-
of jail.
And you checked it for January and it's still showing not active.
We've checked him twice.
All right, check it. Yeah, check 2/1. because it might reactivate without him having to do anything. It depends on where he was incarcerated to, because
He was incarcerated in, he was through, well, this might be part of the problem too, was he was a Washington County Medicaid resident, but he was incarcerated in Warren County.
okay. Yeah, I would check
Jared, I
two,
think if you call
one.
Washington, sorry, I think if you call Washington,
I've called Washington County, I think 4 times, and nobody's called me back, because I called Warren County to see that since he was released in Warren County, and they said, nope, he's a Washington County guy. So I've called Washington County 4 times, and we know how the counties are. They call us, we jump, we call them, we wait. So that's just my
Yeah.
cynicism.
Laura, if you called, so it can be again, that adds complexity to this. I would attempt to call, if they don't call you back, we're already on the 23rd of this month, just check 2-1, and see if it has been I would check 2-1, 2-15, see if it's been reactivated, and then just keep him in diligent search, and then hopefully we can get him re-engaged and back in the program. You might not get paid for
Okay.
it, but we can attempt to get him back in, because obviously he needs it, need come back.
Yes, he clearly
phone calls.
needed it prior to going in. And we,
Yes,
you know,
that's
I
what I would
actually
do.
even sent him a letter while he was incarcerated in Warren County Jail, instructing him that he
Yeah,
would still be with my program and what he should do when he gets out, and then to get a hold of me. So,
yeah, just keep doing what you're doing. That sounds like the best approach.
all right, well, thank you. That makes things a little bit easier on this end, because I'd hate to discharge the guy only for him to pop up on the doorstep February 30th
Yeah,
and have to
he's-
start all over.
It's got to the end of March to pop back up.
Do you
Okay,
know-
thank you.
Just one other thing, do you know if he is a probation officer?
No, he had to serve 3 months and then he was done. There was no,
Okay,
yeah, it was yeah, it was.
he got
nothing
off
like-
easy.
Yeah. Yeah, he was looking at an amount of time, and it was a plea deal where he either would do like 6 months to a year. Oh, wait, let me correct myself. If he didn't take the plea deal, he could do a year. If he took the plea, he was going to do
Okay.
3 months.
Yep,
So he just did the 3 months and that was it.
now he's out.
Yeah, well, I'm
Okay.
assuming he's out because, well, no, he's out. I called the correction officer and he said, nope, he's gone. So,
Jared, if you have, continuing to having issues with the engagement, reach out to us separately and we can continue to troubleshoot behind the scenes and see if we can get it worked out for you.
all right, I appreciate it. Thank you.
Yep. Jess, it looks like there's some questions that have been popping
Yep.
off.
Chat's popping off. So we have a question. The very first policy went over regarding individual status change. Was that an initial appropriate tool completed every tool or CES tool? So anytime there's a status change with the individual, so whether they go to diligent search to enrolled, or they go from pended back to enrolled, anytime those status changes occur, you have to redo the eligibility and appropriateness screening tool, not the CES tool. That would potentially, when their due date is, that would potentially throw off that CES tool. But in order to bill, you have to redo that eligibility assessment, because that has to re-trigger to MAP in order for you to bill. I hope that that answered that question. There was a question in here. It says, health home eligibility and appropriateness assessment needs to be done within 30 days of a status change. Did this mean any status change or just when they go back to an enrolled status? Anytime they're switched back to DS, anytime they go from enrolled to diligent search to enrolled, enrolled to pended to enrolled. So anytime those status changes occur, that's when you would need one. You wouldn't do it when they went into diligent search. You wouldn't do it when they go into pended. It's only when they come back to enrolled.
Did we
Are we
miss any
still
other
able
We
ones?
all
to
allowed
back?
to just
Oh.
whine.
I'm sorry, what was that? Oh, okay. Are we still able to back bill 3 months if a person obtains coverage later? Yes, you can still back bill, but we have seen some issues where they're not backdating the Medicaid, so that would be an individual issue for that person. But overall, Rick, yes, the answer to that is yes, you are correct. Any other questions? All right. I'm all
lot of
set on
policy.
policy.
A lot of policy to go over. Thank you, Jessica and Taylor. And if folks have questions, please reach out and we'll continue to work with you on what you have. Plan of care upload requirements. Just want to remind everyone that health homes across the state are responsible to submit a report to the MAP system through an upload. It's a requirement that's been put in place. And as a result, we have to ensure that our demographics tab is updated within NetSmart. So we've asked over, I think when we had our last meeting in November, when folks are starting to go in as they're updating charts, et cetera, if they would make sure they check off the demographic section, and the things that are now required on there that I've got highlighted in yellow. Primary language is now required on the top right hand side. Gender identity is new and required, which is on the left hand side. Preferred pronouns is new and required, and date of birth is now required. Those are all elements that have to be pulled into MAP to complete the plan of care upload for that individual chart. At the moment, NetSmart has been able to put other information in there to pass it through, basically zeros or leaving it blank or something, some sort of nomenclature that'll let it pass through and upload. But that's not something that's going to continue on for an indefinite amount of time. So we just want to make sure we're updating those charts. So please do so. We don't have a hard deadline date on it at this point. We're just, encouraging folks to really get in there and do that. We have a little over 2/3 of all of our plan of cares in our network uploaded to MAP currently, which is a good thing. I'll get on that deadline in the next slide here, but I just wanted to make sure also that history and risk factors is updated and as well when we're in the care manager plan itself for the plan of care. That is now required. So we want to make sure that we're doing it for both adults and children. And there's some examples here of how that might look. So I'll send this slide deck out after our meeting today. But the example for an adult, the person has a history of homelessness and chronic conditions. They're seeking support with housing and treatment adherence. So that could be history and risk factor for an adult. An example for a child could be they were referred to health home via SPOA. They're SED and the family seeking additional supports to be placed to help support the person. The person has been hospitalized twice in the past 12 months and has suicidal ideations. Just a perspective so that can be put into the plan and understood as it's uploaded into the system. Just said it a little bit ago, as you're getting to it, please, ideally when you're doing plan of care updates, that's the time. But, anytime you're in there, if you think of it, please update that demographics and the actual plan of care itself when you're doing those updates. And then why? Well, as of March 31st of this year, if there's not an active plan of care that's finalized in NetSmart, it's not going to be able to be uploaded to MAP, which means billing will not occur for that person if billing is submitted on that person after the 31st of March of this year. It was originally 1/31. Thankfully, that got pushed out to 3/31. So it's allowing. So it's crucial that organizations understand that 60-day window when someone enrolls, that plan of care has got to be finalized and completed in NetSmart. Questions come up from another number of organizations. Well, what if we print the plan of care off and we have to get a wet ink and we upload that, and that's after the finalized date in NetSmart? We're okay with that as long as it's not, an extensive time after, meaning a month, 2, 3, 4, 5 months down the road that wet ink signature is uploaded with the plan into the system. It should be within, I would say, reasonably a couple week time frame of that plan being finalized. Because it's going to be audited at some point. And if there's a big gap of when that plan was finalized in NetSmart to when it was actually uploaded in the system, that's going to raise some concern. So we want to make sure that we're trying to be diligent about that. As I mentioned a little bit ago, we've got about a little over 2/3 of all of our plan of cares for enrolled members in the network that have uploaded the map currently. Courtney does a weekly poll on that, so she continuously sends uploads each week. So we're in a good spot as far as meeting that 3/31 deadline, and then it'll be a continuation thereafter on a weekly basis, uploaded those plans. Not anything you have to do beyond being sure that those plans of care are finalized and uploaded into the chart and completed within the 60 days. I just wanted to pause to see if anybody had any questions, comments, thoughts. It's happening statewide. We're actually in a good spot compared to some of the other leads right now as far as plan being uploaded, which I'm very thankful for and grateful for, because some health home leads are having some issues with that happening currently. Okay. Next thing, I just wanted folks to be aware, we're going to be developing a training in the coming months. So HIXNY has been able to work with NetSmart to get the ICD-10 codes linked to HIXNY for social determinants of health. So we're excited about that. I don't know if folks who've been around a while recall, it was probably close to 3.5 years ago or so, we did an SDOH training for ICD-10 codes for the network. It was how to link the code to the problem, to the plan of care, to referrals, and it never really took off. It was actually right around the time COVID really started hitting its stride, and priorities shifted, and it just never picked up from there. But with HIXNY linking to the ICD-10 codes for SDOH, that's a good opportunity for us to relook at that. So we're going to be doing some work as a lead to put a training together, and we'll be circling back on that. But I just wanted folks to know that that has happened. It was the 17th of January that NetSmart was able to finalize the linkage between HIXNY and the ICD-10 codes as it relates to SDOH factors. So we're excited about it. We just got to get a training together and get that out to all of you and talk through it. So stay tuned for that. Is there any questions so far? Anything anybody had? I just went way ahead on the deck because I was trying to follow the chat. I'm sorry. Anything I'm missing on questions, Taylor or Jess?
No.
No? Okay. Thank you. Redesignation. So Taylor and Jessica touched on this earlier for that pile of policy that they were walking through. The reason that's driving a lot of a change in our quality and compliance, changing the title, OMEG has put forth compliance regulations. I went over this last fall with the network. As a result, there's some things that we've had to do as a lead, which all leads would have to look at if they don't have in place. And we had our compliance committee that we put in play. We tied compliance factor to our quality program. There's reporting that's going to come out of that. But that all ties back to our redesignation as well. So that type of stuff's going to be looked at redesignation, and the domain weighting for redesignation's changing. So domain one's going to be that a self-assessment when the auditors say, okay, we're going to be auditing your adult and children's program. We're coming out on the next date. We're actually supposed to be due in March of this year for our adult audit, and children would be a year out. So we haven't heard anything yet, but it could be any time. But that domain one is that quality, our self-assessment around how we think our health home's doing with quality compliance and the policies and all the stuff that we have in place, and how does that adhere to the Department of Health standards through policy. And they look at that and they match what we send to them to what policy states, and then they score us on that. So that score is going to decrease to 20% of the overall weight of our designation. Domain two is how we perform as a region on the gaps in care, the health home gaps, the HEDIS measures, all those things related to our lead regionally. That are looked at for adults and children, each individually, the different measures that fall. And that's going to stay consistent as a 20% weighting. That's a tough one for a lot of leads, because usually the report out on that is 2 or 3 year old data. that they're sharing with you, and you're getting graded on it 2 or 3 years later. So it's kind of a sore spot, but that is the process currently. It is going to remain the same. So now you're looking at 40% of our designation according to these standards. So that means that domain 3 is chart audit. So our comprehensive audits that we conduct, the changes that Taylor highlighted earlier, that is getting looked at 60% of our overall score as a lead health home. So how our organizations, our partners throughout the network perform is related to chart audits. And so that's changed a little bit, and that's a big piece that we really want to weigh into. And when Taylor mentioned the 85% as a scoring that could land to a corrective action plan for a CMA, that's driving off from this redesignation standard. In order to hit a 2-year redesignation status, you have to follow overall score between 83 and 88% in order to get that. And as you can see here, if you don't hit that, if you fall under that 83%, you get 1-year provisional status. Now, what does that mean? That means we don't know if the health home's gonna, we're not in a good spot if we get a 1 year. If we get a 6 month, it's even worse. You're really on shaky grounds as a lead and as a network. So we want to strive for at least that 2-year or higher. So that would mean that 83 to 88%. It was 85% until they just updated this redesignation change. When they changed it originally late last summer, it was 85 to roughly 90% was in order to get to the 2-year mark. So that's what brought us to that 85% chart audit, that 10% overall number. So just in case folks are wondering why the hell is 85% going to put me on a corrective action plan? Well, because the standards that the state are putting forth are grading health homes on, if you're not hitting that 83 or higher, you're going to get provisional status as your designation, which is not a good place to be. We have a good overall network scoring. There's always things that happen and come up. We try to work with organizations that have circumstances that arise. We've done a lot of work on a quality policy, as you're all aware, that we've talked about over the last year plus. There's a lot in it now. It's a lot heavier than it used to be as far as content. But the reason we have it in one policy is so we don't have 3 different policies spread out. And the point being is we want to be pretty clear on our step process so that it's not a surprise for organizations if we start to push and look into things further. So that's the why behind these changes. So I didn't know if anybody had any thoughts or anything they wanted to talk about around it, but I just wanted to give you the background to what's leading to us tightening up here as far as our quality and compliance component. Okay. Well, if you have questions, please reach out. We want to partner with folks. We don't want to, have to come in after there's an issue. If you've got stuff that are kicking up because of, staff turnover, if you need a refresher in training, we're more than happy to come out, support, and go through that process. We're more happy to troubleshoot and talk through circumstances. I just want organizations to get in a situation where they haven't said anything, things are just going, and then, issues start to come up, and then we have to react and follow policy. And then people are up in arms as a result. So we want to be proactive versus reactive is what I'm getting at. All right, so that's redesignation and the why behind it. Next topic is just around the 1115 waiver approval. I had sent out to the network last Friday. AHI is looking at the request for proposal for application to be a social care network. There's going to be one of up to 13 identified for New York State due to this 1115 waiver component. 4 of the 13 would fall into the New York City boroughs, and then the remainder would be spread out in regions throughout the state. Our region is pretty much intact to what our health home lead is. The only county that came out and fell into the capital region on how it was carved out was Saratoga. That doesn't mean our health home is not going to be supporting Saratoga. It just means as far as the SCN goes, for whatever entity is awarded to a social care network status, That's how the regions are carved out. We're looking at the application closely. We intend to apply at this point. We're doing a lot of work internally to circle the wagons to put that information together. I just wanted folks to be aware that, it's an exciting time. Health Home was mentioned significantly throughout this waiver approval that Governor Hochul had put forth, and also on the request for proposal for anybody who's looked at that. Health homes are mentioned quite a bit throughout that as well. So that's all wonderful news for the Health Home program for New York State as it relates to social care networks and the 1115 waiver approval. So there's more to come on that, but for now, I just wanted to, mention it to the groups. I saw we weren't in there. I just saw that pop up. Jolene, were you referencing meaning Health Home wasn't in there? It's in there. I can promise you. Oh, Saratoga County. Gotcha. I thought you meant the waiver itself. Yeah, Saratoga County did fall into Capital Region. So that was one thing we were, bummed about, because for our Health Home, obviously Saratoga falls into that net. We're going to be integral as Health Home, as a lead, as Health Home providers, regardless who the SCN is. So the work's not going to change. It's just how do we align with that particular SCN if it were to fall out of catchment. We still have to understand more what that means particular wise in the weeds, but as we're peeling back the application, we will likely be partnering or trying to partner with the SCN who is identified, who has a capital district once that happens. I know our executive director, Karen Ashline, she has done a lot of work, and Eric Burton, prior to his retirement and at the beginning of this year, had done a lot of work just partnering and having a lot of collaborative partnership discussions with all the health systems in the capital region as well as the North Country, and partnering to just continue the open lines of communication in anticipation of the 1115 dropping. So I know discussions are happening behind the scenes of how we can all support each other. Whomever ends up with the primary SCN status, there's still going to be a partnership that's going to occur, secondary to that. But more to come. I just want to make sure folks are aware of it. There's a link here that goes through, the information on the approval document itself. If you haven't had a chance to check it out, feel free if you're interested. And there's a lot of great stuff in there. Just getting it all together is going to be the lift initially. Any other questions or anything around the waiver? Okay. Network providers. I've got two organizations highlighted on here because they both just completed onboarding training to expand program delivery within their organization. So Mental Health Association of Franklin County, so Community Connections, is going to become a children's provider as well. We completed onboarding with them recently, and they should be up and running in the next month or so for that part. So that's going to be in addition to their adult program for care management. In White House, we just recently completed onboarding training with them to be an adult provider on top of a children's provider. So they're gearing up to start that process as well. So we're really excited for those two organizations. And hot on the heels, I don't have it highlighted yet because they haven't completed their onboarding training, but it will be happening in the next week, is Champlain Valley Family Center. So they will be exploring and entering the children's world as well on top of the adult world. So we're excited to add those three programs throughout the region. As you can see, they're all located in various parts of our region in the North Country. So it's exciting news for them. So I congratulate all of you involved with those organizations, and we look forward to working with you in those capacities as well. And then just update on the right hand on the bottom, People USA, St. Joseph's, Open Door, Unlimited Potential, and Step by Step Incorporated are all in the hopper right now. St. Joseph's rehab is pending. They had a merger with another organization little over a year ago. So they put their application on hold, but they're still very much interested in moving forward. It's just on hold at the moment. People USA we're working closely with. They're had some revisions to their application that they were addressing, and it's with the eMedNI Provider Relations Group. Currently, they're out of Poughkeepsie. They have services, mental health out of Warren County. So they're interested in becoming a provider down in the southern part of the region once they're up and running. Open Door Mission would be out of the Warren County area for adults. They're in process of applying to become a provider for MMISD currently. Unlimited Potential is going to be out of Saratoga County, and they're also in process of going through the application process. And Step by Step is our newest addition. They're out of St. Lawrence County. They're an organization that provides mental health services to adults, and we've been working with them, and they've just started their application process to become a provider in our network. So we're continuing to make efforts to grow, and as you can see, become even more diverse than we already are as a network. And we look forward to that continued growth because there's a lot of organizations that can help meet the needs for the many people out there who need these services. And I wanted to congratulate Shelters of Saratoga. They just received provisional designation as a specialty mental health provider within the Health Home Network. So they're able to now start to take Health Home Plus membership clients enrolled in Saratoga County. So very exciting for them. Congratulations to them and their team. So that just happened actually this month. So they're going to get up and running and be able to support that population. Ultimately, predominantly, most everybody who walks through their doors would meet the criteria to be high acuity through Health and Plus. So this is going to be a nice service for the folks that are getting services through them, but also for the organization to help support them. And then lastly, I just wanted to highlight Taylor Dawson, our very own Taylor Dawson, just recently got promoted to Health Home Compliance and Quality Performance Manager. So congratulations, Taylor. That was effective this month. She is, as you could tell, the Quality and Compliance Policy title change. She's going to be overseeing our quality and compliance for the network. Just enhancement of the role she already had ultimately. But we're very excited that this is an opportunity that she's walking into. So congratulations, Taylor. And that's all we had for this month, unless anybody have anything they wanted to talk about, any questions, thoughts? Taylor, you're getting all kinds of...
Yes, thank you, everybody, so much.
It's great. There it is. Seems like people like that decision, Taylor.
Yeah.
It's great. Did anybody have anything else they want to talk about? All right. Well, if not, thank you. And I hope everybody's having a good start to their new year. And thank you for all that you do, as always. And we'll catch up with you next month. Take care, everyone.